Welcome back, everyone. Today we are diving into one of the most beautiful traffic jams in the human body, the nerve plexuses. Dr. Sarah, I'm pumped because this is where the abstract wiring of the spinal cord turns into the actual movement we use to grab a cup of coffee or walk to the clinic.
It's a great topic, Dr. Khan. While it might look like a messy web of spaghetti to students, the formation of the brachial and lumbosacral plexuses is incredibly organized. For the boards, you have to understand exactly which parts of the spinal nerve are contributing to these networks.
Exactly. Before we get into the mixing bowl of the plexus, let's talk about the exit strategy. A spinal nerve leaves the vertebral column and immediately splits. It's like a fork in the road. Why does this matter clinically? Because if you don't know which fork goes where, you can't localize a lesion.
Right. Let's be precise. Each spinal nerve divides into a posterior ramus and an anterior ramus. The high-yield fact here is that the posterior rami are relatively small. They just head straight to the back to supply the skin and the deep muscles of the true back. They don't participate in plexuses.
Think of the posterior rami as the local neighborhood streets, but the anterior rami, those are the major intrastates. These are much larger, and they supply the anterolateral body wall and, most importantly, the limbs. When we talk about a plexus, we are strictly talking about a party thrown by the anterior rami.
Exactly. Now, why doesn't every nerve just stay in its own lane? In the thoracic region, they actually do. We call that simple segmentation. For example, the T5 spinal nerve becomes the T5 intercostal nerve, and it stays at that level. It's a one-to-one relationship.
Right, it's like a ladder, simple and predictable. But when we get to the arms and legs, the outgrowths of the body, everything changes. We need a plexus. I like to use the redundancy analogy. If your arm was supplied by just one single spinal nerve level, a single slipped disc in your neck could completely paralyze your entire limb. That would be a huge evolutionary design flaw.
That is a perfect clinical point. By forming a plexus, fibers from multiple spinal segments, say C5, C6, C7, C8, and T1 for the brachial plexus, all join and intermix. They swap fibers like a relay race. This means the peripheral nerves that eventually emerge, like the median nerve or the radial nerve, actually contain axons from several different spinal levels.
Which is brilliant. It's insurance. If C5 is compressed, your biceps might be weaker, but they aren't dead because they're still getting some juice from C6. This is why when a patient comes in with a limb injury, we have to distinguish between a dermatome, the area supplied by one spinal nerve, and the cutaneous territory of a peripheral nerve, which is the area supplied by the final mixed product of the plexus.
That distinction is a classic board exam trap. Students often confuse the two. Remember, a dermatome is a single segments map. A peripheral nerve, like the musculocutaneous nerve, is a multi-segmented cocktail of those fibers. If you see a sensory loss that doesn't fit a tidy band or dermatome, you're likely looking at a peripheral nerve injury distal to the plexus.
Let's look at the big three plexuses. You've got the cervical plexus in the neck, the brachial at the root of the arm, and the lumbosacral at the root of the leg. Dr. Sarah, what's the high-yield who's who for the lumbosacral plexus?
The lumbosacral plexus is formed by the anterior rami of L1 through S4. It's often divided into the lumbar part, which primarily handles the front and medial side of the thigh, and the sacral part, which handles the gluteal region and the rest of the lower limb via the massive sciatic nerve. Note for the exams. The sciatic nerve is actually the largest nerve in the body, and it carries fibers from L4 all the way to S3.
L4 to S3. That's a lot of segments contributing to one cable. When I was seeing a patient last week who had a massive herniation at L4, he was worried his whole leg would go numb. I had to explain that because of how the lumbosacral plexus works, he'd have specific weaknesses, but other segments would help pick up the slack. Understanding that is what makes you the doctor of choice for patients. You can actually explain the why behind their symptoms.
It's about functional preservation. Also, let's briefly touch on the autonomic nervous system's role here. While the plexuses we've discussed are somatic, meaning they control skeletal muscle and touch, the spinal nerves also carry sympathetic fibers. They use those rami communicantes we see in the thoracic and upper lumbar regions to hop onto the sympathetic chain.
Right, so a spinal nerve isn't just a motor or sensory wire. It's a multi-lane highway carrying somatic motor, somatic sensory, and visceral motor fibers. This is why a nerve injury can also cause a patient to stop sweating in a specific area or lose vascular tone. It's all bundled together.
Exactly. To summarize for the students, the anterior rami of spinal nerves are the building blocks of plexuses. These plexuses allow for redundancy in the limbs, meaning most muscles are innervated by multiple spinal segments. This is the anatomical basis for why we test reflexes like the knee jerk, L2 to L4, to see if those specific segments are intact.
Beautiful. So remember, posterior rami stay in the back. Anterior rami go to the limbs and play mix and match to form plexuses. This creates a safety net so that one small injury doesn't lead to a total loss of function. Dr. Sarah, I think we've untangled this web.
I think so too. The key takeaway: plexuses equal redundancy and protection for our most mobile parts. Keep your dermatome maps and your peripheral nerve maps separate in your head, and you'll crush those clinical vignettes.